without further ado, everybody's happy. Let's move on. Has everybody seen the agenda? Yes. And has everybody had an opportunity to watch the little clip that I sent out yesterday? Yeah?
Yes.
Okay. So what we were going to do is, because I thought, we've had a lot of death by PowerPoint, and we're going to get some PowerPoint during this meeting. But I thought that it might be useful to get just from the participants, other than Tony, some reflections on the video clip that people were asked to look at. And what I was thinking of is to look at, first of all, do you think that could happen in your country? Somebody in your parliament who is a parliamentarian coming out as HIV positive, or has it happened in your country?
I think here in Spain we can't solve that in the parliament, never. And it's the first time. Well, the politicians they are working about the HIV rules, but I think never I saw, or I have seen something like this. Something people speaking with all his freedom about herself, about this HIV situation, personal situation in the parliament.
Thank you, Manuel. From another country? Marios, go on. Marios, tell us about Greece.
I don't think so, that this is a possibility to happen. No.
And,
okay, of course, impossible things happen. For the last 24 hours, it's snowing here. So, okay, it's very, it's very rare. All Athens is white. People were skiing under Acropolis. Really, people were skiing under the rock of Acropolis. So, everything can happen, but, okay.
Okay. Any thoughts from any other countries?
I hardly believe that the word HIV would be soon uttered in Polish parliament.
And Attila is saying the same.
Still absolutely the same. Although,
and, Greg,
there are some rumors that one of the members of the parliament might be HIV positive, but these are just rumors. But the words HIV or AIDS have not been said in the parliament in the last 10 years, and it will not be said in the future as well, I think, which is a shame.
It's not a very HIV. It's not a very sexy topic, I would say, in the country as such. But I wouldn't be surprised, because we had we have many surprises, and we had many surprises. We have gay people out in parliament, and or we used to have. We have a trans person who was in parliament. So I wouldn't be surprised. I think it's I don't know, but I don't think it's impossible.
You don't think it's impossible? Oh, and I suppose the second question is that when it happens, and as you said, Greg, there was a trans person in your parliament, and there have been in the past people who have said or known to be gay in your parliament. What do you think the effect of that is?
I mean,
in Belgium, it's very positive. I would say that we now have a trans woman who is a minister in the federal government, and I have the feeling that it does a lot to the acceptance. So, of course, I don't know what kind of shit she gets over her on social media, but usually when a lot of shit is given to someone on social media, it is reported upon. So I do think it has a positive effect in general.
I don't think it's necessary to go to social media, because our Polish person in the parliament, Anna Grodzka, she went through a nightmare. I think she went through a nightmare in the popular media. That was like it was. I think it was a hell, and I don't know if there was a positive outcome. At least the positive outcome that I see is that people know who is the trans person finally, that they exist. Yeah, that's a positive outcome. But on the other hand, I think she must have gone through a nightmare, because the level of the discussion in the not even mentioning the like common people, but the level of the discussion or the treatment towards her in the parliament itself was like a disaster. It was a disaster.
Julian, I want to talk about a special situation now here in Spain. It's not the same idea, but it's probably similar. The Communist Party in the Spanish Parliament, they are now they are preparing a new law about the transgender people. All the TERF, the feminist TERF, they are crying against, they are arguing against this new law. And it's very rare situation, because I think the communist people, they say it's a good law for the transgender people, but we have problem not all with the far right party. We have the parliament with the feminist, with the TERF, with this.
Some people would say, Manuel, that a TERF cannot be a feminist. You know, that they have got feminism wrong in that sense. But to bring it, you know, so that's perhaps another conversation we need to have. But one of the things
sorry, because it's other idea. But
no, I think it's a useful point to bring. Well, one of the things I was thinking of is that man, the person who came out, was obviously quite nervous as he spoke, even though he was a man in quite a privileged position, a member of parliament, you know, obviously, you know, quite middle class. But you could see the emotion in his as he spoke. Yes, he was going to get an awful lot of shit, perhaps in the media or from some people, but he decided to do it anyway. And he wasn't somebody who was being forced out, because there have been occasions in the past, as Tony and I well know, in the UK, where people have come out about their sexuality or about their HIV status, almost because they were going to get pushed out. Right? But for me, it also says something else. Is that all as activists, a lot of the time, we say to people, it's really good if you can come out as being HIV positive. But at the same time as that, there's always that balance that everybody has the right to privacy as well. Huh? And I think sometimes that's something we perhaps forget, especially with people in positions of power. We say, you've got to come out as gay. You've got to come out as HIV positive. You've got to come out as X or Y or Z. But at the same time as that, people have an individual right to their own privacy about this. So I wanted to put it in that sort of context. But to move swiftly on, because I thought one of the things that might be quite useful is to look at, and I'm going to, let's hope this works. I was going to introduce Tony, and as I said, Tony is, and one of the reasons that I wanted to invite him along was to, as somebody else who'd been there at the very beginnings of the epidemic, and as you will see from the slide, Tony was and still is probably a banner-carrying homosexual when he was sacked from British Home Stores in the 70s. And was was also one of the people fundamental from London Lesbian and Gay Switchboard, who went off and helped set up the Terence Higgins Trust, and also was the chair of a Streetwise Youth, which was
Yes.
for male sex workers. And I wanted to ask Tony, he's also, like Lisa Power, who we were with last week, a living saint, made a living saint by the Sisters of the Order of Perpetual Indulgence. And I wanted to sort of ask Tony a few questions which might help look at, put this in a context. Has stigma changed? How it is different? Has it got any better? Tony, we've seen NPE coming out in 2018. And we've seen at least one other doing so a few years earlier, just before they left Parliament, Chris Smith. But really nobody before that. So I'm wondering whether you can give us all a flavour of the discrimination and stigma in the UK in the really early days of the epidemic. What did it feel like?
It was a time where there's some very vicious, nasty discrimination against gay people, gay men in particular, and it was mixed up with AIDS. It was as though AIDS threw petrol on a fire that was already smouldering. A lot of, I mean, as far back as I can remember, as Julian knows, a lot of anti-gay homophobia, and AIDS came along and it just blew up. I mean, not only did I get nasty things said to me, the kind of posts and phone calls we would get at the office of the early Terence Higgins Trust was absolutely appalling. And in the press as well. I mean, there was no circle of hell too deep that they didn't want to assign us to. It was shocking. I shouldn't have been surprised. I mean, I came out after being at university in the beginning of the 70s, and I got sort of quite publicly sacked for appearing on television programs in 75, I think it was 75, well, around then anyway. I shouldn't have been surprised, but the sheer viciousness of the stuff that was said about gay men in particular to do with AIDS, it was deeply upsetting.
And do you think, I mean, say, what do you think that did? I mean, say, what do you know, because it's a very personal thing, isn't it? What do you think that did to your feeling or other people's feeling of self-worth? How did you cope with that?
I was in I was and am in a privileged position, being very much part of an out gay community and feeling very supported by people like Julian, by people at Switchboard, by people at the young Terence Higgins Trust. So I've always thought it has been difficult, but we gave a lot of support, both formal, the kind of thing you would expect in an organization like Switchboard or Terence Higgins Trust, and informal support. And also very much supported by people beyond the gay community, because we were part of a wider community fighting HIV and AIDS back in those days. So there were some wonderful medical people. There were some wonderful researchers. There were great people I met and worked with who were working with injecting drug users. I was very fortunate indeed that the person who was running the a group for people with hemophiliacs was also extremely supportive rather than negative in the way that some people might have expected. So I was lucky. I lived and worked with people who understood as much as anybody understood. And living in where as I was then in West London, we live in a kind of liberal bubble here, I'm not saying the bubble doesn't get broken sometimes. I've been called names in the street, even, in the last few years, to which my reaction is like, in Kensington? Oh, for heaven's sake, dears. But on the whole, I think I've been very lucky. I used to work on the telephones at Switchboard and at the early Terence Higgins Trust. And the stories I listened to of people, sometimes in parts of London, but throughout the country, and the fear they had of disclosure about HIV, and the fact that they were daily confronted by the negative press, which we would clip and keep in those pre-email sort of days. But the fear they lived with when they go out of their house, the fear that they would be identified, and there were cases where people were identified and bricks were put through their window, and I think in at least one case even a firebomb. That's the life people had, not me. I was so fortunate.
Yeah, and I think that Tony paints a picture. I mean, so remember the front page of newspapers. Gay stands for got AIDS yet. 1984, the Daily Mirror.
Yes.
There
was another one I saw as a graffiti: AIDS, anally injected death syndrome.
Yes. I'm just wondering whether I think that within the context of the pandemic in the UK, mainly being almost exclusively being amongst gay men. I think that one of the things that in the later in the 90s was some of that solidarity and knowing what it was like to be marginalized, knowing what it was like to be shat upon, actually created some of the conditions where there was a certain amount of solidarity between different groups. Not always perfect, but it laid the conditions of knowing for gay men who were living in the bubble, before that, who had suddenly realized that that their freedoms were being taken away, that other people were experiencing that as infections started to happen amongst, up until about 85, 86, 95 or more % of the cases in the UK were contracted men between, MSM and gay men in the main. But I'm just wondering, before we close this little section, whether anybody has any questions or observations for Tony. The floor is open.
I have a question to Tony. Tony,
thank you.
Tony, was the most motivation for you to come out was more with self-stigma or more discrimination, stigmatization outside of in your words?
Well, coming out as a person with HIV or a person, a gay person?
No, not gay. I'm not talking about gay. I'm talking about stigma for HIV.
It was important for me with the kind of public role that I'd taken on, because I did, speaking and news interviews and the rest of it. As soon as I knew I was HIV, and I tested as soon as I could, I thought it was just important for me to be open about that, because I thought it could give some hope to people that I had HIV, but actually I think I looked pretty good in those days, I didn't, I wasn't ill, but also because just being honest is one of the most powerful ways to fight against stigma. And stigma nourishes things, I think.
What if you didn't come out as a gay yet? Were you still going to come out for HIV before coming out as gay?
I think a lot of people have found that very difficult, because HIV was so and is still so identified with being gay, but particularly them, come out as HIV was taken as coming out as gay. And I can understand why that was a great challenge to a lot of people who didn't live the sort of, supported, open, metropolitan life that I've been able to live. You couldn't say you had HIV really without them asking questions about where it came from, how you got it. So in a way, you had to disclose about your life, remembering that it was mainly, as Julian said, gay men in those days in London, not entirely and certainly not now, but in those days it was mainly gay men.
Attila.
Just a short comment. Have you all seen the new series, It's a Sin?
Yes, I'm following it.
I think everyone should see it. The importance of this series is that it talks to the younger generations who do not have personal experience regarding the first days of HIV and AIDS. And I think I'm grateful for this series because it talks to the TikTok generation.
Yes.
And I think it's very, very important. That's my
and the last scene between the mother and the friend is very, very, very special. The last scene, but I don't talk about this because if anybody don't watch yet this film, I don't want to talk.
Yeah. Don't give us spoilers.
The spoilers. I don't like the spoilers. But the last thing, the last image is so interesting idea because they are talking about the shame. It's very important.
Oh, don't spoil it because I can only take it one episode a week. I find it very. It moves me a lot, and although their experience wasn't mine because I was older and I was working already from 83 within gay organizations within the Infant Terence Higgins Trust that I joined, so my experience was not theirs, but I recognize their experience, the young men in that, because I talked to them every day. And because, I had a life outside the trust, I would go clubbing and I would, be dancing around, even though I was a little bit older than them. I won't tell you how much older. But so yes, I think it's a good program and a great contribution to the debate, but it is only part of the diversity of the experience of people with HIV.
Thank you for joining us, Tony. I mean, so I think that, you are welcome to stay for the rest of the and a half that we have left, or you can do something more exciting.
Well, I just say thanks. Oh, there was one thing I did want to mention. I mean, I still get called names today, Julian, sometimes. I walk arm in arm with Paco. I love him, but also because my eyesight's so terrible. And we often get some very funny looks. But years back, around the time you were talking about, one of the strangest and most unpleasant things I suffered was people shooting at my windows in my flat with an air thing. So it wasn't like bullets. But this was in '89, just after my lover had died. He died here in my arms. And I was at a low ebb and someone was shooting at my windows. And it's difficult to say whether prejudice like that, the kind of emotions that drives people to do that, is anti-gay or anti-HIV. I think that the two were and still are to a large extent inextricably linked.
Yes, they are linked in terms of being marginalized, and I think it's important to remember, especially as other people have been talking about young people. And we're going to talk quite a lot about the internalized stigma that still is with us today. In however much we have normalized HIV. The realization of that internal stigma, as we saw in the MP, is still something that we very rarely talk about how being othered talks about, and then Marius is going to talk about that. But I think it's something that sometimes as activists, when we're talking about stigma, we don't look at how we're dealing with our own internalized stigma because of the way that we are viewed as other.
Yes.
But thank you, Tony, my love.
Yeah, I'm glad to be here. I welcomed, and I shall probably listen in for a bit. Okay.
Do that. Okay, so moving swiftly on, you're now going to get a death by PowerPoint by me. Sorry about that. Or a little bit of it, and I'm going to try and make it as. And I wanted to concentrate upon internalized stigma, as well as looking at the PLHIV stigma index, and also looking at some elements of the difference between stigma and discrimination in various ways. Okay, so hopefully everybody can see the screen. This is a very long presentation, but some of it I'll just skip through, and it will be available later, as well as some of the resources and references to it. When we look at stigma and discrimination, let's look at okay, stigma is perceived as being different from others. And I'm going to talk about the fact that stigma can cause feelings of despair, guilt, shame, distress, hopelessness in all of us. And internalized stigma, when a person views themselves differently, and we're going to look at why. And an easy way to typify the difference between stigma and discrimination. Stigma is being viewed as different from others, while discrimination is being treated differently. There's one way of looking at it in terms of a concept. And I think that when we look at this, we have to realize how pervasive the power is and what different forms there are. And whatever programmatic interventions we do in terms of stigma, in terms of creating enabling environments, we don't necessarily create enabled or resilient people unless we have got in our programmatic work and the way that we look at, unless we look at some of those self feelings about self. Here is, that's one of the simple ways of looking at it. This is a framework to look at that I find most useful. It was created by Anne Stangl and others, and it was a result of a lot of the literature that you look at will look at stigma in a particular domain. Mental health is the big one. It will look at it from a particular perspective, but it doesn't look at it. Very few look at it as a cross-cutting intervention. Very few talk about the intersectionality of different types of stigma that is looked at. So, ranging from fear of infection through casual contact, which is the concerns about productivity, people being got rid of in their jobs because, of course, if you're HIV positive, you're going to be sick, or if you're HIV positive, you're going to necessarily infect somebody, all the way through to chronic conditions, to authoritarianism, social judgment and blame. If you look at the drivers and facilitators, the drivers, we say a fear of infection, of fear of social and economic ramifications, lack of awareness. People don't know how HIV is transmitted. Social judgment, bad people, blame, stereotypes, prejudice, and these can do. So if you look at stigma marking and intersecting stigmas, race, gender, sexual stereotypes, occupation, class, and then we move on to the way it manifests itself. Experienced stigma and discrimination, internalized, perceived, anticipated, or secondary stigma. And we'll talk more about what anticipated stigma is in a little while. So the stigma practices, stereotypes, prejudice, stigmatizing behavior, discriminatory attitudes, and the outcomes. You know, they can be about access to justice, the right to health, uptake of testing. I don't want to find out that I'm part of this group so I won't go and test. Because, you know, the way that people are viewed so badly. And then, you know, in terms of organizations and institutions, laws and policies, the way the media treats people, the right to health, law enforcement practices, and social protections. That's a very complicated way, and I put the complete abstract that comes from in a resource list for everybody. And it is open access. It is very useful, and unlike an awful lot of stuff or research on this issue that I tend to read, it's actually quite readable. So I would recommend it to you. The simple way, perhaps, of looking at this that we did for the Stigma Index. Okay, what's the difference between stigma and discrimination, and what's another way of typifying it? And here's a sort of mind map that we drew up as part of our one of our Stigma Index workshops in Nigeria, actually. So, you know, it starts off with a prejudice and a thought. That's pretty internal. And then you look at a stigma being an attitude. That can also be about discrimination and act. And of course, as we've had in previous things, is that because somebody is discriminating against you doesn't necessarily mean it is actionable. And we talked previously in a session about, of course, how many countries in Europe, for example, have something like the Equalities Act in the UK or Hate Crime Act in Ireland. Sometimes people can still discriminate against you. In other words, they can act against you in a discriminatory manner, but there is no redress in law to do anything about that. But wherever it comes from, the results for a person living with HIV are loss. And their loss, you know, you can typify them in three ways. Self-worth, how it makes you feel. Legal freedoms, in terms of what you are or not allowed to do. And of course, it actually is taking away your human rights. And as we've also discussed, sometimes your human rights are not actually protected under the law of a country. You know, they're a treaty. There's something which may or may not be able to get restitution about. So that was, you know, one way of looking at it. This is an internalized stigma workshop that I'm going to flash through, but I will look at later. For any of you who are doing work with people living with HIV or are HIV positive sitting in the room, this has proved a very useful mind map for therapeutic work or thinking about things. So we defined it in this way: perceived stigma, what we think others are thinking negatively about us. And, you know, self-stigma in some ways is about people stigmatize themselves to a greater extent than HIV positive negative people actually stigmatize HIV. It's like that thing of the person who thinks, you know, who knows that they're gay and doesn't want to walk through the door of the pub because of what people might think. You have to say to them, well, yes, but the people on the other side of the door, the reason they're in that gay bar is that they're also gay. Or the person who comes out, as Tony and I both had in switchboard things. Oh, I don't want to have that coming out to my mother, coming out to my family. And the fear of what might be said actually sometimes being completely different from when they do come out and their mother says, we've known for a long time, we were just waiting for you to tell us.
Yes.
So that sort of thing. An active stigma, discriminate, actual experiences take place. Self-stigma, negative self-judgments that actually adversely affect our health. I think we know. So guiding questions for this exercise that we've gone through is asking people what is their self-limiting belief. What do you think will happen? What's your inner voice telling you about your status? How is this belief linked to your status? And what is a more empowering belief? And I'm just going to run through. We looked at fear-based beliefs around disclosure, or what they might be. We also looked at perception of the thoughts of others. And later on, after this, look at this and think, if you're HIV positive, how much you have behaved or behave in relation to those things. And if you're not HIV positive, put yourself in those shoes for a moment when you're working with clients or doing work with clients, because they are good little therapeutic tools to look at the impact of stigma. And we see this in non-health seeking or non-empowering behaviors. Those are the sorts of things that just here. And of course, people living with HIV who haven't dealt with these things internally, or sometimes, and it's not always the thing of always being empowered. Sometimes I think all of us are living with chronic illness conditions can exhibit signs of those burdens. And the last one, what does it do to our sex lives? What does it do to our intimate relationships? And what are the thoughts that we have about that in relation to mainly what we have been taught and what we have to unlearn about some of the stereotypes, prejudices, lies that we have been told about people living with HIV, about who we are, and sometimes, there is still AIDS phobia amongst people on Grindr. There's still AIDS phobia generally with everything. So that was just a little mind map that I thought might be useful. I'm going to move on to the people living with HIV stigma index now, because this is the one of the ways of quantifying on what people think about both the way they think about themselves and the domains of work, family, medical care, political, legislative, and criminal laws that might affect people. It is, as it says, a tool to gather evidence on how stigma and discrimination impacts upon people living with HIV. It operates under the following principles: JIPA, it being owned and led by people living with HIV, and embraces an environment that celebrates inclusion of all the types of people living with HIV. You can find more information about it on the Stigma Index website. It has been, its first iteration was there in 85 countries as of 2017, when I stopped working on it for GMP. It was then updated to include or to try and drill down more into intersectionalities of different types of people living with HIV, whether it was sex workers, drug users, transgender, etc. And so it's had a new iteration. One of the things about the PLHIV Stigma Index, and there are other tools that one can develop, is that, as you can see, it's a pretty deep tool which is one of the criticisms against it, is it requires an awful lot of lifting. It's quite an expensive tool to implement. But the other part of it is that because of the way that it is structured, and because it is a tool where you can compare across countries, and because it has been validated by academics, you can publish it. People take it seriously. Governments, researchers, the policymakers. There are other tools around, but what I would say is that it always look at the methodology and whether it has been validated by somebody, because we can all go off and do small pieces of research about stigma and discrimination to try and do advocacy to change things. But if it's not a tool that is recognized as being a good instrument, then unless you've got a very good in to your policymakers, your Department of Health, is it going to create change? I think that anecdote, sometimes a very powerful anecdote of the way that somebody has been discriminated against and why this should change can work. But I think that less and less so we need to have hard data and hard evidence. That's all I'm going to say about that. And it is, the background to it was, communities, and it's a tool for GPA enactment. And we'll talk about the way that, of course, all that research is no good unless it is one which is something which also has an advocacy agenda that goes with it. And one of the reasons that the Stigma Index was put in place is that we as a community have been researched so many damn times, and then we knew that it became a nice little policy document 2 years down the road, feeding the research agenda of the institute that did it, but actually didn't affect real change. I think one of the things about the PLHIV Stigma Index is that it is action-based research. And as I said, those are all the domains that it looks like I'm going to I've just taken the results from one country. It's a European country, and this is one question, and it's specifically looking at internalized stigma or self stigma. Can anybody guess the country where 48% of participants blamed themselves for their HIV diagnosis, felt guilty about having HIV, felt lowered self-esteem? Go on, pick a country at random.
Latvia.
No, the other end of the continent. No.
Portugal.
Nearly. You're getting closer. You've gone further down, but now go further east.
Spain.
Yeah. Well, okay. Much further east.
Greece.
Much further east.
Italy.
Much further east.
Ukraine.
No, come back a little bit.
Romania.
You're nearly there.
Slovakia.
I'm going to give it to you. It's Moldova. But it's very interesting, and I don't know whether it's just people shouting at random to get this slide over, but it's very interesting in that if you look at the results of most of the countries, you will see that there is nowhere where zero people say, I blame myself. There's nowhere that people have lowered self, deemed or feel that they might be punished or judged. So it's a pretty constant thing across an awful lot of the countries, and the majority of the countries where those residual feelings still exist amongst people living with HIV. So as I say, one of the things that we perhaps need to do when we're looking at stigma is that, yes, we can gather all this wonderful stuff around around how people are discriminated against, you know, not given left last in the queue for health services, or not given employment, or discriminated in employment, and such like. But unless we have dealt with these feelings of, or worked with people to look at this internalized stigma that we feel because of all the shit that has been laid upon us because of our status, right? We will not create resilient people that even if the doors are open, they're not able to walk through. So that self-empowerment is really important. So we've got a section later on, which is where we do advocacy around it. So unless anybody has any burning questions around that or thoughts, I'm going to stop sharing my screen and then move on to Greece, and get the wonderful Marios Artemis to talk to Greece and drug user perspective and other things. The floor's yours.
Okay. First of all, I have to say that I'm really impressed from your presentation, Julian, and it was really. So I have to
just go on, carry on.
do my best, to keep the audience. After that, also, it was a very good idea that you called Tony. It's historical, and it's very nice because let's say we, the younger generations, let's put it like that, we tend to forget some things. I still remember how it moved me when I watched this film, How to Survive a Plague. Anyways, I'm moving forward to my presentation. Look, it's a long presentation, so we don't have to do it all. We can skip some parts, and we can start from a definition of stigma, because it's a Greek word. It's an ancient Greek word, and it has a kind of an origin and a history. A stigma, which plural is stigmata, is an ancient Greek word used in modern Greek as well. Stigmata were visible scars imposed on convicted criminals, people who were defined as traitors, or deviant slaves. Stigmatized people were ritually stained, disfigured, and everyone should avoid them. In modern Greek, the word stigma, except some medical terms regarding skin diseases, has exactly the same content. Stigma is actually imposed on the socially deviants, on vectors of an illness, and of members of minorities as perceived from the dominant rules of society. This is a preface in the Greek edition of Stigma from Goffman. Finally, the way in which the person allocates his body is evaluated based on his ability to control and discipline passions and abuses, including sexuality. Inability to control testifies to the prevalence of sensation and emotions, and in parts of the body, a materiality which undermines his spirituality, as the flesh follows desire. In other words, the mood and use of the body betray negative traits whenever they deviate from socially defined correctness and normality. In other words, stigma is imposed on the ones who are considered that they are having their body available for the wrong reasons, for the dominant rules of society, either sexual reasons or reasons of drug use. This is also from the preface of Stigma in Greek version. In the case of a drug addict, I'm translating exactly as the Greek translator made the preface, so it's not politically correct terms, but it's exactly like they were published back in the 70s. In the case of a drug addict, the homosexual, the prostitute, but also the pimp, the ex-convict, despite the difference, the discreditable behaviors belong to the category of stigmatized, not just because they trample social norms, but mainly because their personal biography has been burdened by evidence stating the misuse of their body. This is the stigma by Goffman. It's visible all external deformities, known deviations in personal characteristics, and racial discrimination. That was, Julian mentioned the Stigma Index inquiry. This is the results. Because the organization I work for, I used to work for actually, Positive Voice, made this inquiry, Stigma Index. So stigma and discrimination continue to overshadow the life and everyday life of people living with HIV in Greece, according to the Pan-European Survey. Stigma Index conducted in our country from Positive Voice in a sample of 500 HIV-positive individuals. The findings of the research highlight the difficulties faced and the fear experienced by people with HIV in all aspects of their lives, such as personal and romantic relationships, family and friendly environment, professional sector, and healthcare. Despite the fact that the majority of participants, 67%, choose not to disclose their HIV positivity, about 3 out of 10 of those who lost their jobs in the last year declared that they were fired because of HIV in the health sector. 15 experienced discrimination reaction when disclosing HIV status to health professionals. 11% faced refusal to provide medical services. As you can easily imagine, this thing happened to me as well. I was denied medical assistance twice back in the days. I'm talking about 10 years before, when it was very obvious that I was a drug user, because I was very thin and you could see the bruises on my hands from the injections. And so I had this infection on my mouth, on my tooth, and I went to a public doctor, and she actually said, no, really, I can't help you with, because it's not my problem, but my nurse and my assistants really cannot deal that you are an HIV positive. And I said, how the hell you know that I'm an HIV positive? And she replied, because you are a drug addict, you're very thin, and we are full of migrants. So they transmitted HIV to you. I said, okay. I will never forget the day, actually. Anyway, also there is a huge stigma, not only to the personnel and the doctors. It's not only about the personnel and the doctors, but also about the mental health professionals. In Greece, it's shocking the level of the stigmatization and the discrimination the mental health professionals, like psychiatrists and psychologists, have towards the HIV positive people. It's really shocking, and it's much more shocking when these guys work for harm reduction structures and for treatment units, because they deal with people that they have blood-borne infections like hepatitis and HIV, and really these guys need to educate again. We have to re-educate them again and again, to get over it. Really, they live in a different century and in a different sphere of perception. Anyways, I'm continuing with that. Fear of revealing their seropositivity is one of the most powerful levers of isolation of HIV positive individuals in Greece. For people who use drugs or are recovering from problematic drug use, stigma can be a barrier to a wide range of opportunities and rights. People who are stigmatized for their drug involvement can endure social rejection, labeling, stereotyping, and discrimination, even in the absence of any negative consequences associated with the drug use. The translation to that is that even if you are in recovery for many years, only your reputation in the neighborhood, in the professional environment, and somewhere else can actually ruin your life, because you are going to be always the junkie, and they will finger pointing at you. And sorry for getting too passionate about that. This manifests in a variety of ways, including denial of employment or housing. People with substance misuse issues are less likely to be offered help than are people with a mental illness or physical disability. According to the research, the majority of healthcare professionals hold negative stereotype views of people who use illicit drugs. Stigma is a major factor preventing individuals from seeking and completing addiction treatment and from utilizing harm reduction services such as syringe access programs. In a vicious circle, the social exclusion created by stigma can increase the needs for a variety of services. That was a research made from the Drug Policy Alliance. Even among people who use drugs, stigma toward other people who use drugs can be common. Women who use drugs and people with comorbidities like a mental illness or bloodborne infections are highly stigmatized by other users. Women suffer physical and verbal violence, tend to be characterized from other users as immoral, ruthless. I won't mention the other word, but you can read it. From men drug users. People who use drugs, people who inject drugs with mental illness are probably the most discredited subgroup of drug users. They are literally pariahs within the pariahs, as addiction specialists call them, in order to represent the stigma and the dehumanizing exclusions they suffered from their own community. This, with other contributing factors, leads people from that subgroup to be suicidal and much more self-destructive than the others. Another contributing factor to that is the lack of an effective treatment model that leads these people to despair and to self-doubt if they can heal or not. I can translate that. Because, okay, this is my personal experience in treatments with people of dual diagnosis. Okay, in order to defend myself, that happened like 11 years before. I have to admit the following. I was in a substance-free treatment, a tough love community. And if you had a mental illness, the whole mentality of this community, but also the mentality of the majority of the people there, including me, I'm very sorry to say that, it was like we were afraid of these people. First of all, we were avoiding them, people with mental illness, and we were considering them as inferior from us. And when a person deals with this kind of discrimination in a place which from definition should be inclusive and non-discriminative, usually he will fail to his purpose. He will drop out from the community because he feels unwanted there and he feels marginalized there, as he is already marginalized in the society. In Greece, it is, it is very rare to have communities, especially treatment units, especially designed for people with comorbidities. Actually, there is only one in Athens. Athens is a city of 5.5 million people, not included the undocumented migrants and the refugees, and one in Thessaloniki, which is the second largest city. So these people actually are the most stigmatized, most marginalized from the same, from our community, which is, you know, sometimes it's really scary what is going on with people with dual diagnosis, with comorbidity. This is my favorite part. You know, if I could, you know, say what was going on with me some years before, I could actually say everything from here. You know, this is the internalized stigma, is the, you know, this feeling guilty for using drugs just because society thinks it's wrong. Being grateful when treated as a human being, especially in public healthcare services. Blaming drugs for harms caused by prohibitionist drug policies and the war of drugs narrative. Conflating drug use with addiction. Believing addiction is an incurable disease. That makes me really angry when I hear that. Viewing ongoing drug use as something degrading and unacceptable. Identifying with the offender, the Stockholm syndrome. You know, the cops say that you are a lost case, the psychiatrists say you are a lost case, the majority of the society says that you're a lost case, and then you start repeating to yourself, yes, I'm a lost case. You know, they're probably right. You know, they know better than me. That's the story of the life of many people I know, and it's a vicious circle. I had to make a very important psychotherapy to get over all these things and to stop identifying with the offenders, to stop identifying with you know, the major beliefs of the society about the drug users, how, you know, mentally contaminated we are and physically degenerated. Yes. So here we're going to have a trigger warning. I think that you already talked about this case in the criminalization section about HIV. Okay, what we actually can tell about this case is that the women drug users were actually used as the ideal scapegoats 2 months before the elections. 2 ministers, the Greek Center for Disease and Control Prevention, some doctors, and some journalists, they made this mess. The police were out in waves, in open drug scene. They arrested only women drug users, and they forced them to make an HIV test inside police cars or inside police stations. The women who are resulted positive, not only they knew that from the police officers with a very vulgar way, but they were driven to jail. And they were driven to jail because they were accused of being sex workers who intentionally spread HIV virus in the Greek society. I was in a treatment with one of these girls, and she told me the whole story. It's a horrifying story. These girls were actually declared innocent in the tribunals they followed, and but some of them committed suicide, and some of them, they're not exactly, let's say, well after this trauma. Their photos were actually in public view in the internet, in the news, for like 2 months. There were, you know, it was primetime news in the central TV stations of Athens, And the photos of these girls were parading the one after the other. And the subtitles under these photos was, "These are the drug users, sex workers who are contaminating the Greek society with AIDS." There is a documentary film about that. Marina told me that they actually mentioned that to you. It's called Ruins. A friend of mine has done that. The director is called Zoe Mavrodi. That was actually the most characteristic case of how you create a scapegoat from the drug users, and how do you use this scapegoat for political reasons. I think we are okay. I think we're done. Somebody has a question or whatever, a comment?
Fabulous. Thank you, Marios. Are any burning comments or questions to Marios, or observations before we move on to Luca?
Can I ask, do you have any organizations that empower the women, the drug users? Is there like an organization they can go to try and express or get help with what they're dealing with, or are they just left to face it alone?
No, thank God. There were organizations like the one I worked for, Positive Voice, the Greek Association of People Living with HIV. There was another organization called Center for Life. There were also some feminist groups that were very actively engaged in this chaos. And also some very good people from treatment units that they personally engaged with these girls, because most of them were very problematic drug users, of heroin injecting drug users, and they needed support. It one of the most shocking things I've ever faced in a treatment unit. I've been in treatments for as long as I live in my adult life. Okay, and I have listened to many different shocking stories, and too much group therapy, too much drama therapy, too much traumatizing narratives I've been listening. But the worst of it, the most shocking, is when I met this girl on that treatment, and she told me exactly what happened from the moment she was on an open drug scene, from the moment she was arrested, till the moment she was driven to jail, and how the policeman actually announced to her that she is an HIV positive. This girl lost her voice for 6 months because of the major shock. So when I met her in the rehab, she couldn't speak, so she was writing to papers, and that was the way she was participating in the group therapy sessions. And gradually she started telling some words, and then she actually talked again after 6 or 7 months. We are friends, and she's good right now, but not all of them were that lucky. 3 or 4 girls have died, 2 committing suicide and 2 from an overdose. It's a very sad story. Yes, you should watch Ruins, this documentary film. But yes, thank God there was a supportive network after all that happened.
Okay.
I just put the link of the movie in the chat as well if you haven't seen it. It's on YouTube.
Shall we move on? If we have one more presentation from the fabulous Luca, then we will give ourselves a an opportunity for 20 minutes of conversation, because I think it's been a rich discussion. But otherwise, it's us just talking at you.
All right, so I'll be fast. I think, can you hear me? Yes. So hi, my name is Luca, and I'm the coordinator of ICRAC, which is the European Sex Worker Rights Network. I'm French, but I lived most of my life in the UK, in London and Scotland, and I just moved to Brussels. And yes, it just feels very funny because I had a Britney Spears moment today and I just shaved my head. So I just don't really recognize myself. And I have a cool t-shirt that says decriminalize sex work. And in the back, Rights Not Rescue. So I'll briefly talk about sex work stigma. I did try to have my colleague Stacy to do the presentation, so it was not another white guy presenting, but sadly she couldn't make it, so apologies for that. So quickly about us, we are a European network of 111 organizations working with sex workers or led by sex workers. Our network itself is led by sex workers. So I've been a sex worker for many years, and all our board members and staff, etc., are sex workers. I tend to speak very fast, so maybe just shout if I go too fast. So we do advocacy for sex workers' rights. We mostly at the European level, we do training with sex workers, etc. So I just wanted to share these first few pictures, which are from the World War II, actually, I think, or World War I, no, World War II. And it shows sex workers as vectors of contagion. So as you probably know, like sex workers have always been associated as being basically a health threat to the soldiers, to the nation, to, in that case, like to the victory in war. So basically having sex with a sex worker was a high risk of getting a venereal disease. And this was, as the posters say, a toast to Hitler and Hirohito. And you can see that like sex workers are portrayed as like, you know, dangerous and deviant, etc. Then this, the same conflation of sex workers as vectors of contagion was seen as well during the HIV crisis, and even recently with the COVID crisis. So at the beginning of the COVID crisis, you had many media reporting of sex worker, like a prostitute with COVID, infecting clients, seeing 15 men a day, etc. So this conflation of sex work as vectors of contagion is one of the main aspects of the sex work stigma. Of course, it's not the only one. So the reason why sex workers are stigmatized, I mean, it's pretty obvious. But in many cases, sex workers are already part of other already marginalized communities. In particular, women. Of course, the majority of sex workers are women, both cis and trans women, or are part of the LGBTI community, in particularly trans women, but not only trans men as well, non-binary, or MSM, if you like this word, I'm never sure about it. So gay men, etc., gay, bi. There are many migrants, particularly in Europe. The majority of sex workers are migrants, so either from Eastern Europe, from Africa, from Asia, from Latin America. A large number of Roma people as well are involved in sex work, as well as people who use drugs, and of course, working class people or poor people, and people living with HIV. And so there is a kind of, as Marius was saying with the case in Greece, an overlap of different stigma. In particular, in this case in Greece, it was like sex workers, homelessness, people who use drugs. One stigma we don't often talk is also like around like mental health, with many sex workers also having mental health issues, and maybe not like more prevalent than in other populations, maybe it's still to be discussed, but it also impacts how sex workers are being treated. So how it works is that stigma and discrimination of sex workers impact our access to health, but also to justice, to education, to housing. And sex worker stigma is actually not only touching sex workers themselves, but often any woman or any person who don't behave as a sexual norm dictate, and even in some cases, the family or the children of sex workers. So in some countries, for example, in Bangladesh, many children of sex workers were not allowed to go to school because they were children of sex workers. And it was this stigma associated to them that school was not allowed, was not open to them. And sex workers and their children, they fought like many battles in Bangladesh, and now they managed to change the situation. And now the kids of sex workers are able to go to school. And for many of them, it's also then the opportunity not to turn to sex work in the future because they have more opportunities. In Turkey, is the same situation. I don't know if it's still the case, but for many years, children of sex workers had a little stamp in their passport, which prevented them from having jobs in different sectors, including education, police, army, etc. Maybe it's good that they were not allowed to join the police, but anyway. And the main way the stigma and discrimination work as well is that sex workers and the organization are usually excluded from policy making. So most laws and policies that impact sex workers are developed without the involvement of sex workers. And we know now that, particularly in the context of HIV, it is really crucial to include sex workers. It's recommended by the World Health Organization, the UNAIDS, sex workers themselves, of course. And this is something that we've also been calling for in the COVID crisis, that all the laws and policies that are currently being developed to stop COVID, to flatten the curve in the first wave, etc., should really be developed with the most marginalized communities, including sex workers. And we've seen in the second and third wave, like a little bit of change that now some governments are starting to include sex workers more. Like in Belgium, for example, although sex workers were mainly excluded at the beginning, there's now been funding available and consultation with sex workers, and even talks about legal reforms in order to give sex workers a status and include them in conversation. There's no easy way to address and fight stigma, because the stigma on sex work is so prevalent and is actually related to so many issues, in particular like stigma against women who don't behave in a way that is seen as acceptable by society. But we see that in some cases, what we are recommended is like community empowerment and community building. And this is in particularly very important to fight internalized stigma. So for example, like now I'm really happy to say I'm a sex worker. I've been a sex worker for a long time. I speak in panels, etc. But, at the beginning when I was doing sex work, I was ashamed of it, really simply said, I was not doing it because I enjoyed it. I did it because I had no choice at the time, and it was the only way for me to make some money. And I was really ashamed of it until I met other sex workers, and I was able to get rid of the stigma, etc. I don't know if you ever really get rid of the stigma fully, but to some extent. We also encourage community alliance building with other marginalized communities, in particular LGBTI communities, migrants, labor, in order to strengthen links between organization and fight the stigma as well within other movements, social movements. When it comes to access to health, one of the main recommendations is community-led services, that sex workers should be involved in the development of programs, HIV, but not only. And also many sex workers and organizations develop referral system to say, for example, okay, if you go to this hospital, this one doctor is excellent. They really have no problem with working with trans sex workers, for example, you won't be discriminated. So supporting sex workers this way. And of course, what we are advocating for is the decriminalization. So the full decriminalization of sex work, not the Swedish model, which is currently being promoted across Europe and globally, which criminalize clients and continue to undermine sex workers' rights. As you can see, this was a very fast presentation. Maybe it was too fast, but I usually think most people know about this, and it's kind of obvious. So it was just to give a background. But to give you one example, because I think it was interesting at the beginning, we talked about Stonewall, and we had a Tony, and I know Julian, and there was a link about Lisa Power in the conversation. But just a funny story about Stonewall. So Stonewall is the main LGBTI organization. You might know, but until recently, they didn't work on trans rights, for example. It's quite recent that they include trans people. And on sex work, they never worked on sex work. And then when I was living in London with our organization, and we were many LGBTI sex workers, we were trying to get Stonewall to take a position on sex work. And we wrote them letters, and we were like, hey, guys, many of us, trans, gay, others, bi, we work in the sex industry because of discrimination in education and other work. And anyway, whatever the reason we are selling sex, we should have rights. It doesn't matter if you do it because you don't have a choice or because you enjoy it. That's not the problem. And Stonewall always ignored us completely, not even responded to us. Recently, they approached us our organization, so Swarm, the organization I started in London a long time ago, and they were like, yes, we want to start working on sex work. Do you want to be a partner? We got funding for it, etc. So a trans sex worker joined. She was like, yes, this is so exciting. 1 month later, they emailed, they were like, yeah, we changed our mind, actually. It's a bit too dangerous at the moment to talk about sex work because of the issue around trans rights in the UK, the backlash. So basically they say, okay, we don't want to work with you anymore. And now 1 year later, I got an email from Stonewall. They're like, okay, we want to work on the issue again. This time it's for sure, we're going to work on it. But for me, this is, you know, from the LGBTI movement, it should be so obvious that we need to work on sex workers' rights because some of the most marginalized LGBTI people are sex workers. But actually within Stonewall, because of the politics of kind of like respectability, and we don't want to offend our feminist allies who don't like sex workers and are a bit on trans issues, actually it took forever for them to start working. So we're not there yet. I'm hoping at one point they get a clear position. It's a very small example. There are millions more, but I thought that was interesting because it seems Stonewall is a theme today.
Thank you, Luca.
Voilà, that's all I had to say. Thank you.
Fabulous as usual. And seeing as you were showing off T-shirts, I'm showing off my T-shirt. I'm Priscilla, Queen of the Stigma Index. We've got some 28 minutes, and I thought a way of what we've been doing really is talking about a great deal about intersectionality, how stigma, you know, we need to look at intersectionality through a stigma through an intersectional lens, and we need to appreciate and realize the self-stigma or the way that we discriminate against others when we're working. So I thought a useful way of prompting a conversation was going around the room and thinking of, because I'm quite sure that all the people in this room have done advocacy to combat stigma, and looking at what works, what does not, some country examples, and also within that, or apart from that, questions on solidarity, how we work with other people who are not, who are not from the type of person that we are, living with HIV or impacted by HIV, and how sometimes we perhaps don't work as well as we could with, you know, those people, whoever they might be. So that was just a way of framing the discussion. But before that, if everybody has anybody has some questions for clarity or definition or comments upon Luca's presentation, let's start off with that. But other than that, I was thinking that might be a good way of framing our discussion around that in that sort of way. Thoughts?
For me, something new or something that I liked a lot that I think I haven't heard of before, or kind of didn't think of it maybe, was stigma or like exclusion from policy making, decision making as stigma. This I find very interesting because, this is strong somehow.
That was a very good point, actually, the exclusion from policy making.
But I think on this as well, what's interesting is like the class issue. Like, you know, I'm a white guy, kind of middle class. I can speak the language. That's, you know, what I've learned now, how to speak the language. But for many migrant sex workers, like it's often being used, even within sex worker organization, you will see that it's being led by like more respectable sex worker who can use the right language. But sex workers who are more marginalized, etc. Sometimes like there's also this like tone policing, like, oh, you don't know how to speak appropriately in a meeting, and you shouldn't be too angry, and like this kind of thing. So often they use that as well to like exclude sex workers and other marginalized groups.
Look, one question, sorry. You are talking about the sex workers and the feminists. For me, it's a problem because we are working, helping the sex workers. The women's sex workers, do you know, this is the big group when you compare to the men sex workers or wanted to compare with the transgender sex workers or trans girls sex workers, the more big group is the women, the cis women workers. We are offering rapid tests, we are offering information, we are helping them share if they are migrant girls. Then when we are talking with my friends, and sometimes it's appear a feminist, she said, if you are working, helping the sex worker, you are continuing this discrimination process for the women, because we are abolitionists, and the only solution is the abolitionist. And I feel bad because I'm the first question I make for all the girls, sex workers girls, do you feel good? Somebody is making obligation for you. How do you feel? We can help you with, we have a psychologist here. And I feel bad when the feminists say, the only solution is the abolitionist. The abolitionism.
And, I mean, you're from Spain, no? You're from Spain?
Yes, from Spain.
Yeah. So my last meeting before the whole like COVID and travel ban and things like this was in Spain, in Valencia and Madrid with Médico del Mundo. So I'm also like a volunteer for Doctors of the World, the French chapter, which is kind of like the mother chapter. And we went to Spain to meet with Médico del Mundo because although they provide services to sex workers, they are abolitionists and they believe that, you know, prostitution should be abolished. Like, I don't really care what people think about prostitution, if they think it's great, if they think it should be abolished, but what they need to look at is the concrete results of policies. And in the case of abolition, the policy is criminalization of clients. And this is really just seen to not work. You know, it's been going on for 20 years in Sweden, 5 years in France, 5 years in Ireland, and it's a disaster. Violence against sex workers has increased, precarity of sex workers has increased. There's absolutely no evidence that is doing anything good for sex workers. And what is difficult sometimes to debate with feminist abolitionists, and Spanish ones are quite specific as well, is that they really are ideological. You could show them the millions of reports. You can show them all the academic evidence. They will say like, yeah, but this is not right. And this is funded by OSF, and this is funded by the pimp lobby. Oh, HIV, yes, of course, we know who's behind this. Like, they really have almost a conspiracy theory and completely ignore the evidence. And so it's really difficult to build alliances in this way. All we have to do is keep repeating the same thing that, you know, it is not protecting sex workers. Yes, you can be abolitionist, but then you should call for like, you know, economic measures against poverty, open the borders, trans rights, and all the reason why people turn to sex work in the first place. But using the police, our argument is this, is that you are calling for more police in the workplace of mostly migrant, mostly women, drug user, trans people. The police is not our friend. If you believe the police is our friend, then, you know, for me, this is not the right type of feminism. But then it's very hard to make any progress in these conversations.
Thank you, Zoe. I agree, of course. But it's very difficult because the feminist girls, they are only in this. The solution for that is abolitionism, and is. How do you know? This is not the solution, of course.
I think Luca brought up a very interesting point about Stonewall, about, you know, suddenly sex workers became the flavor of the month for Stonewall because they could access funding. And then they thought, oh no, this is too hot, so we're not going to work on sex work. And then a year later, they come back and they say that to you, you know, we want to work with you now because we've worked out our own little thing. And I think it's about part of that thing of when we work, trying to build alliances, to what extent can we build alliances that are not there because we don't believe that the principles of engagement the vision, the beliefs that we have with those other movements or those other organizations are actually there. And sometimes I think it's better to say, no, you don't share our mission, you don't share our principles, or we're only going to do it in a very strategic sort of way. And I'm wondering whether anybody has got any examples from countries of where they've tried to do anti-stigma or anti-discrimination work, and what worked and what didn't. Any thoughts?
Can I say something, Julian? Can you hear me?
Of course you can.
Yeah.
Yep.
The last slide you had, it was about advocacy and solidarity, and I wanted just to add something regarding to that. About drug user advocacy in Greece, but in Europe as well. It's a common secret that HIV was the Trojan horse for drug user advocacy in Greece. Before the HIV outbreak back in 2010, 2013, we did not have such thing as drug user advocacy in Greece. It was unspeakable. You are considered a total crazy junkie that if you say I'm going to advocate about my community, because they could say to you, you are totally individualized, you're marginalized, you junkies don't have a sense of community and a sense of solidarity, you're stealing each other, you're killing each other for a dose of heroin. What do you want about advocacy? Come on now, man. But during and after the HIV outbreak, the public opinion were so scared, so horrified, but then so sensitized about the drug user issues, about bloodborne infections, and we used HIV as a Trojan horse to bring our agenda into policymakers and to say that we are not defending the drug use, we are not defending the heroin dealers, we are defending the public health, and we are defending our rights. And about solidarity, what I have actually understood throughout all these years is that we are being emancipated through our users' unions. We have this sense of collectivity and this sense of solidarity because we have the European network of people who use drugs, the international network, and the local users' unions. It's a sense of really an emancipating process for us to belong to a group and to fight for the same purpose, and also to share the same lived experience. It's very important for us to share our experience because we cannot share it, in many places, that was I hope this makes sense.
No, absolutely. I think there's always a image of in any country. I think that the UK was one where, yes, the majority of the early infections were amongst gay men, and they still make up the largest number of people living with HIV. But there was almost that thing of it's like Maslow's hierarchy of oppression, in that it took an awful lot of work to turn around and say, well, we're the nice people living with HIV. We're not the dirty people living with HIV, i.e. drug users, or we're not the people who are not indigenous white people living with. I think that in any country, in most countries in Europe, where there is one group that is larger than another of people living with HIV, one of the things that separates us is not working on that intersectionality, of not confronting our own prejudices about other types of people living with HIV. I think that's one of the great shames, that we haven't managed to pull that intersectionality together. I think it's got a great deal better in the UK. But I often wonder about how much work people do to make sure that to create that solidarity, and also to confront the prejudices that one has about other people, because you have them whether you like them or not. You know, I think it's a given.
Really, I have a question, small question for Luca.
Yeah, go for it.
Yeah, Luca did say he doesn't believe well into men who have sex with men. Can I know why? And after that, also from the beginning of AIDS, it was said that it's more a disease for gay people. But we know also back then also there were still men who have sex with men. But how come they never managed to point out also that there are also heterosexual people who have sex with the gay men and then take it home, something like that? But still, the stigma was only related to gay people, not to men who have sex with men. Thanks.
Yeah, I didn't really mean anything by it. I just find the term MSM a bit funny and very like this HIV lingo. It's like key population. It's like, oh, you know, I'm a MSM, key population, PWUD. You know, like I do find it a bit weird. And, you know, I'm gay, kind of, obviously. But for me, like, I do feel like when I was a kid or a teenager, I was being discriminated because I was not very masculine, not because I was having sex with men, you know, like lots of men have sex with men and are not discriminated because they do it, you know, hidden way. And like, so I do feel like there's a bit of sometimes a weird way of like talking about men who have sex with men. But the same with sex workers, like we know that there's many like straight men who sell sex to make a living, and they should be able to have access to services. For example, like in Greece, we work with like a Positive Voice, like the same organization as Mario, and like many refugees, for example, like refugees from Syria, including like young people, sell sex to survive, you know. And I don't know how they would define themselves. They wouldn't use, you know, like, I don't know, like they are straight, like they wouldn't even define themselves. They just do like survival sex in order to survive. So this thematic of like MSM is just a little bit strange, but
it was first coined to not stigmatize against men who had sex with men who didn't identify as gay. So it was about that whole thing of the difference between behavior and identity.
Yeah.
And yes, it has become really problematic, I think, for an awful lot of reasons.
But it's the same with like, you know, sex workers, like, you know, I love sex worker, I'm a sex worker, but lots of people who sell sex they don't define as sex workers, and it shouldn't really matter. Like, yeah. I think sometimes we focus so much on like this naming and identifying that it becomes ideological. The same with people who use drugs. I mean, like, I don't know how, Marius, you define, you know, like, if, you know, sometimes reclaiming like, yeah, I'm a junkie, or I'm a drug user, or I'm a guy who uses drugs. Like, you know, sometimes like, oh, you have, and in the movement, then if you don't use the right word, it's like, oh, you know, sometimes it's like, yeah, I'm a prostitute. Like I was a prostitute since I'm like 16 years old. And sometimes I want to say it just to remind people that, yeah, we're talking about prostitution there. You know, it means like sucking cock for money. That's what I'm talking about. Like sex work is almost too dry. And the same with MSM or people who use drugs. Like I know we fought to be recognized as this because we want to say, yes, it's work, or yes, we are not just drug users, we are people who use drugs. But it becomes a bit like, in my opinion, sometimes too detached from the reality of like lived experience of people. I don't know.
A big question that I wanted to ask everybody was whether they think that general population programs reducing stigma actually work. Because let's face it, in Europe, so much money has been spent upon them. Right? Of that, those, you know, and I'm just wondering whether people think they work, or whether they think that targeted work within communities work better, or actually spending all that money increasing the resilience of the people most effective is better.
So if I can jump in, I come from a very privileged background. I'm white. I come from Europe. I have privileges that other people don't have, even here in this group. So for me, I was diagnosed 9 years ago. I came out with my HIV status nearly 3 years ago. And I could only do that because of all of the millions of people that died before me. So the way I've kind of labeled and been able to deal with my diagnosis is to put myself in the people that aren't here today. So we're talking about labels and we're talking about different groups, but I think ultimately it has to start with us and it has to end with us. And I mean like you as your person yourself. So when I decided to come out with my HIV status, I can't impact what other people think about me, but I can certainly give them the words and I can say things about myself that they can then say. So it starts with me. I can only influence my friends and family. So what they thought about HIV was completely different to when they found out about my story. So not me being white, not me being gay, not me being anything else, just me being Andrew, I was able to influence my friends and my family. I've been able to do that then with the wider community, and then I've been able to do that nationally. So yes, I do think targeting key populations has helped because that's where I was able to come out myself. Seeing that British MP come out in 2018, in the video himself, he said that he was diagnosed for 10 years and look how long it took him to come out. So I understand everybody is very different and not everybody can come out, but it takes, like I was my own worst enemy for my first 2 years and I'm only here today because of the help that I've got from different organizations. So we definitely need funding from key populations. But again, my message today is it starts with you. It's what can you do with your friends, family, community, and then join up with other people like we've got today. So that's what I'd like to add.
Thank you, Andrew.
Can I say something?
Yes, of course you can, Anne.
Andrew, thanks for that. Unfortunately for us as Blacks here in Europe, it's different, as you know. And it's very difficult for us to come out, especially women, because we've got a lot to lose. We've got our families, whereby it starts with us and then it goes down to our children. When the children come out, when you come out, it affects the children and affects the friends and everybody else. And it actually takes a long time for people to come out, which other people have done that. And there's some other people that are still on the way or on the road to come out. It's very difficult. I'm going to speak on the Irish, like on where I am here in Ireland. It's only recently that people, I think, are starting to embrace people that are living with HIV. But before that, it was very difficult. And people were being discriminated and there was loads of stigma. But I think because of education now, people know about HIV, and I'm finding it easier nowadays to talk about HIV to people than I would have maybe a year ago, and all because there was a stigma campaign that was started last year in 2019. And that stigma campaign, the posters were actually put in places, in public places like the train and the trams and the luas and the bus stops. So when people are going, maybe when they're boarding the bus or the train, they would read U equals U. And I think that just the spots where these campaign posters were put has actually helped a lot of people understand what HIV and where we are right now. And then also this, it's a scene. This series that have come out, a lot of people now are talking about it. And I think after COVID, cross fingers, when all this COVID is over, I think it's going to be time whereby there's going to be a celebration of life, a celebration of, yeah, we're out of COVID. And then what next? We still have HIV. Let's also go back and start dealing with HIV because we left it behind because of COVID. Now let's pick where we stopped and carry on. Thank you.
Thank you. Yeah.
Can I say something? Yeah, about as Andrew said, thank you again, Andrew. It's true. We face different stigmatization when it comes also to Black and migrant. Like, for example, my experience is like I have 3 different experience with the stigma within health professionals. First time when I came out of for the closet, I lost my volunteer job in hospital here in Netherlands. We are talking countries in Europe. You're supposed to think like in hospital they are more aware of HIV or protocols, but to fire me because of I said I'm coming out, I have HIV, but more than 10 years living with it. HIV is not like I got it yesterday, so I tell you now. You know, it's very it's not very encouraging for many people who would lose their jobs, really job, paid job, who dare to come out when you know you're gonna lose your job and what gonna do, you know? And of course, how I dealt with my children at school, with the parents, I was well prepared, mentally strong, know what is coming, and I fight it until today. I am open, and because I fight that day, I was not afraid. I know what is coming. Then that's why today I have my freedom. But doesn't mean that it has stopped. Every time I face discrimination or stigmatization, I stand up, I speak out. So that is what, as Anna said, is and Andrew, you have to start from individual, from you. Go slow. You don't have to be open publicly, but you can at least have a small family, a small group for backup in case things goes wrong, you cannot take it anymore, and then you have people who can support you. Thank you.
I think, you know, I'm always conscious when, you know, once again, as an older white privileged queer, that you know, I always have to say that you know, it's like when I say it's really great that I'm on treatment, but it's a privilege. I know it's a privilege that is denied to others, and I also know that you know, I have come out as HIV positive, but it's quite safe for me to do so. It's relatively safe for me to do so. And I think it's that whole sort of thing that those of us who are in that position where for us, for whom it is to a certain extent, always need to turn around and say, but of course it's not safe for everybody, and not demand it of anybody either. You know, you know, we all have to respect that, and I think that's a really important thing that sometimes as activists we don't actually recognise. No?
Can I come in there? Can you hear me?
Yes, certainly, Tony.
Oh, we'll just briefly say, yeah, absolutely. You're totally right. It isn't safe for everybody, and you cannot expect everybody to follow your own example because you can't walk in their shoes. But just a couple of points. I mean, I remember when I first came out to my parents about being HIV and told them there was going to be television programs and all sorts and the rest of it. And my mother watched the programs wonderfully. And the only criticism she ever made of me was, it was most interesting what you said, dear, but why on earth did you wear that shirt? And so I was in your position. I was very fortunate. I was supported by community, supported by friends, I was supported by family. And I've always recognized that very few people perhaps are so fortunate as I was to have that kind of love and support around me. And also living, you know, in cosmopolitan West London and other cities in the world that were similar. We can't force people. We have to find ways of empowering people.
Yeah, thank you. And I think that on that note, I'm going to bring this to a sort of end. because I think that one of the things is that is the other reason for using tools around stigma and discrimination, where we document properly and research properly, because then we can microphone the concerns of other groups who are not able to stand out public with robust evidence rather than anecdote. And also, we also need to work on ourselves about how we deal with our own self-stigma, and also how we see the intersectionalities of people living with HIV who are different from us, and how we can take the lead of how they need to be supported, or how we need to work together much better than what we do. Thank you ever so much. There's all the things from this session will go online, and there's also a resource list from the criminalization session, and all of those who are going to do the really exciting things on of the next session that I'll be with you for, which is about program development and fundraising and things like that. This will be the start, I will warn you now, of looking at how, because some money has been gained, how you might like to develop projects as a result of being involved in this program to actually implement at a local level. So that will be the first taster of what those projects might look like and planning those projects. So there we are. It will not be really boring. We'll try and make it exciting. Have a good evening, everybody. Thank you very much. All right, bye.
Bye-bye.
Thank you so much.
Bye.
Good afternoon.
Bye.